Welcome to the view from the Thoraxcenter for Radcliffe Cardiology. My name is Nicolas from Mieghem. Next to me, my good friend and colleague Joost, Daemen. And today we are reviewing the late-breaking clinical trials from the ESC 2025 meeting. The dust has settled down. And let's start with the first randomized controlled trial. This was yet another trial from the Leipzig group, from Holger Thiele and Mohamed Abdelwahab. This is a German-driven center, multi-center, with a 2x2 factorial design. And they were comparing two self-expanding valves, the evolute valve with the accurate valve, but at the same time they were also randomizing patients to local anesthesia only or conscious sedation. I think conceptually an excellent study, very interesting and very relevant for our clinical practice. But unfortunately, in the patients that received local anesthesia, 70% had temporary pacers and 30% even received an urinary catheter. I mean, this is not according to our practice of local anesthesia, and that might have affected the outcome, because if we compare the patients under local anesthesia versus conscious sedation, there was no difference in the primary endpoint, which was a composite of mortality, vascular and bleeding complications, infections requiring antibiotics and neurological events. At the same time, there was approximately 20% crossover from the patients undergoing local anesthesia to conscious sedation. That is not a surprise, because from time to time the perception of pain is different from one individual to the other. So up to a third of the patients crossed over, when they crossed over, did that because of pain. And then also 1 in 5 because of anxiety. So I think it is you would see the crossover. So if you did then do an as treated analysis, then all of a sudden the local anesthesia outperformed conscious sedation. So I think in terms of the of sedation protocols, I think we are on the right track. In Erasmus, we are doing the majority of our cases under local anesthesia. And for whatever reason, if a patient becomes uncomfortable, okay, we give some midazolam and some fentanyl. But I think that works very well. And in our own data set, we did find less delirium, less infections. Those differences were not demonstrated in this trial, but I think it is important to keep that in mind. If we then compare the two self-expanding platforms, that was a big surprise, because comparing the accurate valve that is no longer available, no longer commercially available on the market, versus the established evolute platform, turns out that the accurate valve outperformed the evolute valve in terms of the primary outcome, which was a composite of death, stroke, more than mild paravalvular leaks, and pacemaker rates. 15% versus 13% in this composite primary endpoint, but all driven by fewer pacemakers. So 11% in the accurate group versus more than 20% in the evolute arm. I think the major takeaway here is that it's, I think, unfortunate that this valve platform has been taken out of the market, because as you can tell from these data, it is a well-performing valve in the right setting and also in the right hands. So you need to be trained properly, and then the results would have been or can be very good. And this platform probably has the best-in-class pacemaker rates. So that is double choice.
Yeah, double choice. Interesting study. What it tells me, I think, is that the local anesthesia practice is safe. It increases efficiency. But I think what I also learned from this data, if you looked at 25% crossed over or had need for sedation, is quite interesting, because that's not something we would echo in our practice, at least not this number. And if you set this up in your practice, I mean, setting up the whole team, having a nurse on the head of the patient, informing them upfront, every step of the procedure needs to be explained by a nurse who's really with the patient. And I think that could have been a driver of the somewhat lower rates of bailout in our cohort. And for the valves, we alluded already in the preview that this would be a bitter pill to swallow for Boston. And the pacemakers is a thing.
Yeah, published in Circulation for those of you who want to have more granular information. Then let's go to the second trial involving valve platforms. This is the VANTAGE trial. I had the opportunity and the privilege to present for the first time data with the Navitor valve. This is a prospective study, not randomized, looking at how this valve is performing in patients at low or intermediate operative risk with symptomatic severe aortic stenosis. Up to that point, patients could only be treated with the Navitor valve when they were at high or prohibitive operative risk. So we were looking for opportunities for different labeling of this valve platform. The primary effectiveness endpoint was the occurrence of more than mild PVL. The primary safety endpoint was at 1 year and was a composite of mortality or disabling or fatal stroke. Now, this trial was quite favorable for the valve platform, so no mortality in the low-risk patients, single and like less than 2% mortality in the intermediate risk population. And if we then look at PVL rates, no patients with more than mild PVL. So excellent results. As a matter of fact, if we look at PVL, also only 15% had mild PVL. All the other patients had 0 or only trace. So that tells you that this platform has matured and has become quite a good alternative or a valuable asset in everyday clinical practice. The downside of pacemakers, we have to acknowledge that. So it was around 15% in the low-risk patient population and 21% in the intermediate risk population. To put that in perspective, if you look at the pivotal Evolute low-risk trial, pacemaker rates were also 17%. And also in VANTAGE, we were not applying the cusp overlap technique. We also have now an improved Navitor valve with a radiopaque marker. So the expectations are that for that now also in clinical practice, we'll see lower pacemaker rates also with this platform. So I think very well received data that was also published simultaneously in JACC Cardiovascular Interventions and also resulted in CE mark for treatment in patients with low and intermediate operative risk. So I think mission accomplished.
Important milestone, absolutely.
Yeah, important milestone. And the big challenge obviously is currently ongoing in the United States, where there is a randomized controlled trial ongoing, the ENVISION trial, comparing the Navitor valve with commercially available valves, that is the SAPIEN valve and Evolute in the United States. And obviously there are no foregone conclusions there because we know what happened to the ACURATE IDE trial. So we'll have to wait for those trial results probably by the end of next year or even in 2027. So enough of the TAVI scene. Let's move to why not heart failure?
Yeah, so ESC obviously a meeting with a lot of focus on pharmacotherapy as well, and a couple of trials that we wanted to highlight. The first one is VICTOR. So VICTOR is the large multi-center randomized controlled trial designed to test if vericiguat reduces CV death and heart failure hospitalizations versus placebo in patients with heart failure and reduced ejection fraction who have not been previously hospitalized. That's important because the predecessor of the trial was called Victoria, which actually had more or less the same design, but then focused on patients with recent heart failure hospitalizations. So this is obviously a less diseased patient population with a drug studied in Victoria that was highly positive. So a significant and a beneficial effect of vericiguat in reducing CV death and heart failure hospitalizations
in sicker patients.
In sicker patients who had been recently or previously hospitalized. This trial, 6,105 patients, near class 2, ejection fraction below 40%, 519 sites on a pretty well controlled heart failure medication. 95% was on beta blockers. About 56% on ARNI, 60% on SGLT2s. Mean pro-BNP is 1,300, so clearly less than in the previous trial. And 50% had no prior heart failure hospitalizations. So a little bit against what was expected, no difference in the primary endpoint, 18 versus 19%. But then something which was a little bit odd is that there was a disconnect between the event rates in terms of cardiovascular death and heart failure hospitalizations, which typically go hand in hand in these heart failure trials. Well, this trial did show a 17% decrease in all-cause death and a 16% decrease in cardiovascular death, which is quite significant, and also met the criteria for significance within the study. But in terms of heart failure hospitalizations, there was no difference. There was a 5% lower rate in the vericiguat arm, but with a p-value of 0.6. So basically, no statistically significant difference. Then the investigators looked a little bit into a combined endpoint of hospitalization or escalating treatment. That had a trend towards significant, but basically, didn't meet the endpoint. Then Javad Butler subsequently pooled the data with Victoria, and a meta-analysis resulting now in 11,000 patients to perhaps get a little bit more granularity on how this data should be interpreted, concluding that the drug resulted on top of guideline recommended therapy in an 11% relative reduction in cardiovascular death and 8% reduction in heart failure hospitalization. So with that, a drug that adds something to the, let's say, golden four of drugs that are currently being used, but perhaps a little bit more or a little bit less effective as to the risk reductions we've seen, for instance, with the SGLT2 inhibitors. So to me, and that was also a little bit what was discussed, a drug that may help, but you may question, again, another drug in patients who are already taking a lot, and perhaps the future lies in the combination pill therapy that will not increase the absolute drug burden, but may intensify treatment a little bit.
That's so therapy compliance. I think this is a very relevant comment. And then the other thing is the cost effectiveness. So what is it? What is the cost of this drug on top of all the other drugs? And then I think we may need to put that in the proper perspective. So I'm not sure whether we will see this in our everyday clinical practice anytime
Well, that's
soon.
the question. And it's likely not the best drug for patients who are in decompensated stages. That's something also we learned from this meta-analysis. But yeah, let's see. Let's see. Another trial that we looked out for is the digit heart failure. So the randomized trial on digitoxin in patients with heart failure reduced ejection fraction. So again, not digoxin, but digitoxin, a somewhat less toxic agent because it's also excreted due to with the liver instead of the kidneys. The trial envisaged to enroll 1,600 patients on NIA class 3 or 4 heart failure and an ejection fraction below 40%, or NIA class 2 and an ejection fraction below 30%. The trial enrolled quite long, apparently. At the end, intention to treat analysis was kept on 1,200 patients after funding evaporation. The trial enrolled for I think 5 or 10 years, which resulted in 20% on SGLT2s, 70% on MRAs, 40% on ARNI. So not bad, but there is room for improvement, you would argue. And then at 3 years, apparently a positive endpoint, an absolute reduction in the primary endpoint of all-cause death or hospitalization for worsening heart failure with 4.6%. Absolute reduction, which translated into an 18% relative risk reduction. So quite interesting, and not something that echoed the results with the digoxin 30 years ago. So clearly more explicit result of this drug. Conversely, if the investigators presented the Kaplan-Meier curves up until the end of the follow-up in which they clearly came together. So yeah, there is an effect, but whether it's that strong on top of what we currently would classify as optimal heart failure therapy, I think still remains to be determined.
But super cheap.
Super cheap,
so if you could choose for vericiguat or digitoxin?
Good question. I think though the nuance here is the population studied. So these were clearly patients that were already more advanced in more advanced stages.
But there you have Victoria.
Failure.
Victoria showed the same thing in patients who had recent heart failure hospitalizations.
Correct. But these were really 3 or 4. So this, I think, was a bit more stringent even in terms of what would be eligible for enrollment. But fair point.
But you know, also the uptake of SGLT2 inhibitors and ARNIs was not that high. It was less than 50%. So I think today we are treating our heart failure patients a little bit better.
Absolutely.
Current guidelines are just so much more strict in these golden 4 applications. So I think the number of patients that will qualify for this treatment will be very low. But it's good to have that, you know, in the back of our mind. If you keep getting these patients back despite the golden 4, then digitoxin might be a
good alternative or good add-on.
Yeah. So then another trial in the heart failure setting was the DAPA-ACT heart failure TIMI 68 randomized controlled trial. And we have seen a multitude of trials demonstrating the benefits of SGLT2 inhibitors. And in this trial, 2,400 patients with acute heart failure, regardless of their ejection fraction, were randomized to either an SGLT2 inhibitor or control. The median age of the patients was almost 70 years old. 20% were black people. Ejection fraction was less than 40% in 72% of the patients. And again, ARNIs only in 27% of the patients, so not that high. Patients had type 2 diabetes in up to a third. So 2 months of dapagliflozin versus control. And what happened then at 2 months in terms of the composite of all-cause death or worsening heart failure? Well, there was no significant difference between the two treatment strategies, although there were trends in favor of patients who received the SGLT2 inhibitors. A little bit disappointing. I would have said up front, or we said during our preview, that this would be a positive trial. Well, unfortunately, it was not. But at the same time, if you then pull all the data in the literature, focusing on these patient populations, you do see that dapagliflozin will reduce major events in these patients. So I think definitely when a patient has been admitted with heart failure, yes, they need to receive an SGLT2 inhibitor, but maybe you have also time to start this medical therapy, because we typically get all the big four in the race, but maybe you can also titrate up a little bit, and it is not really necessary for the early outcome to get these patients on an SGLT2 inhibitor.
Yeah, that's absolutely true, but you can also look at it from the other side. I mean, the trial also demonstrates that it's safe to administer it immediately, and you know how it goes. You need to see these patients back. You up-titrate a little bit more every visit, and then suddenly you have 6 to 8 visits. I mean, this drug has no penalty in terms of hypotension, or typically it's very well tolerated.
And so you don't titrate either. So
and you don't have to titrate. So to me, to me, the message is there's no penalty in starting early, and in a drug that proved to work.
Yeah. Fair point. But then beta blockers in the context of an acute myocardial infarction. Do we need to put all these patients on a beta blocking therapy? And we had the REDUCE-MI trial that focused on patients with an ejaction fraction of more than 50%. Well, turns out that beta blockers doesn't make any difference. This time we were looking at patients in 2 randomized controlled trials, basically in 3 randomized controlled trials. There is the BETAMI trial, the DANBLOCK trial, and then there is the REBOOT. But BETAMI and DANBLOCK, they had very slow enrollments. They suffered from the COVID pandemic, so they decided to join forces because they more or less had the same trial design, not exactly the same, but still good enough to try to combine both trials. So patients were enrolled in Denmark and in Norway, more than 5,000 patients. So a significant number of patients who had a recent myocardial infarction. Patients had to have either a STEMI or a non-STEMI and an ejection fraction above 40%. And they were then randomized at discharge or within 2 weeks of the index event. In this Scandinavian study, so Denmark and Oslo, the majority of patients received metoprolol. So no bisoprolol or other beta blockers, so metoprolol, 50 milligrams, and the median follow-up was 3.6 years. The mean age of the patients, 63, 20% were women, STEMIs in approximately 50% of the patients, and the ejection fraction was less than 50% in 15% of the patients. The primary composite endpoint was a combination of all-cause mortality, recurrent MI, revascularizations with PCI or CABG, ischemic stroke, incident heart failure, or malignant ventricular arrhythmias, or CPR of cardiac origin, and a minimum of 6 months. But again, we had a median follow-up of 3.6 years. Turns out that there was a 27% relative risk reduction in terms of myocardial infarction. And if you look at the composite overall endpoint, there was a 15% relative risk reduction in favor of beta blocking use. I think this definitely set the stage for the REBOOT, because the REBOOT was a trial not in Scandinavia, but this was in Southern Europe. So in Italy and Spain, 8,500 patients. So this is not a pooling of two trials. No, this is 8,500 patients, more than the 5,600 from the two other trials pooled together. And patients were then randomized again to either a beta blocker or control in the context of a recent STEMI or non-STEMI with an ejection fraction of more than 40%. Mean age was 61, so a little bit younger. Again, 1 in 5 were women, and 50% had a STEMI. The ejection fraction less than 50% in 11% of the patients. Here, the primary outcome at 5 years was the incidence of MACE, so all-cause mortality, reinfarction, or heart failure admission. And guess what? There was no difference between the two treatment strategies. So beta blockers did not make a difference. And as a matter of fact, in patients with an ejection fraction more than 50% and predominantly in women, there was even a signal of harm. So totally different outcome findings in REBOOT. Is that because of geography, or is it because of how the trial was done in the respective trials? It's a little bit unclear, but they then also pooled the data and focused on the patients with an ejection fraction of less than 50%. Both trials were published in the New England. The meta-analysis, the pooled meta-analysis, was published in the Lancet, and that again showed that in more than 1,800 patients, 1 in 5 women, the composite of death, MI, or heart failure hospitalization was significantly lower in the patients on beta blockers. But then all of a sudden it becomes a different trial, right? Because the purpose of those trials was, well, if you have more or less a preserved ejection fraction, do you have a benefit of beta blockers? Well, I think there the answer to that question is no, because you have 2 randomized controlled trials that are negative, and then you have 1 randomized controlled trial that at the end of the day is a pooling of 2 trials that had slow enrollments. That was a positive study. So I think in aggregate, this all points in the direction of, no, you don't need to put all patients after a myocardial infarction on a beta blocker. And this is good news for a lot of the patients, because you do see 1 in 5 of the patients complaining of, fatigue or erection disorders and so on and so on. So I think if the ejection fraction is more than 50%, no reflexes anymore of beta blockers. Between 40 and 50%, probably you can consider it, especially if the underlying heart rate is still on the high end. But otherwise, I think you need to discuss with the patient, and you may even keep the beta blocker out of the equation.
I think you nicely summarized it, and nothing to add there.
Well, and even more on the treatment of patients with ischemic heart disease. This is the REFINE-ICD. And we are all familiar with the implantation of ICDs in patients with depressed LV functions. Well, this trial from the United States, Canada, and Europe enrolled 700 patients who had a prior STEMI or non-STEMI at least 2 months prior to study enrollment, with an ejection fraction between 35 and 50%. And this is of interest. There was an additional enrichment by Holter and EKG. So patients had to have heart rate turbulence or T-wave alternance on Holter and EKG respectively. Patients were then randomized 1-to-1 to an ICD or no ICD, and the primary endpoint was all-cause death at a minimum of 18 months. So 2,000 patients were identified with a prior MI at least 2 months ago, and they underwent an ambulatory EKG testing and Holter monitoring to look for these high-risk features, so the heart rate turbulence and the T-wave alternance. So of those 2,000 patients, 597 patients eventually were randomized to ICD or no ICD. Well, before randomization, turns out that the patients with this high-risk feature, based on the Holter or the EKG, they had a hazard ratio for mortality that was 2.59 versus patients with no enrichment features. So I think that tells you that it makes total sense to do like risk stratification based on EKG and Holter monitoring. But then the major message from this randomized controlled trial was that during this mean follow-up of around 5.7 years, there was no difference in the primary endpoint between the two treatment strategies. So whether you inserted an ICD or not, it didn't make a difference in terms of mortality, cardiovascular mortality, and even sudden death. So I think this, we really see a change in the landscape, because we already know that in non-ischemic cardiomyopathies also the benefit of ICDs is contested. Well, this is part 2 of the story. It's also now contested in patients with a recent myocardial infarction. So I think the threshold to provide and to treat these patients with an additional ICD becomes higher and higher.
Yeah, which makes sense, right? I mean, the risk of sudden death and ventricular arrhythmias is obviously linked to the burden of fibrosis and ischemia vulnerable tissue, and that obviously is less in patients with an ejection fraction of 50% as compared to 20%.
Yeah, but okay, we were looking for patients with depressed ejection fractions. So
depressed, but not poor. And that, I think, is the critical difference here.
But I think the major explanation of the findings now is that, you know, the pivotal trials with ICDs, they stem from 20 years ago. And, you know, we have become so much better in revascularization, in medical therapy after revascularization, but also in heart failure medical therapy, right? Yeah. So I feel that, this is a blow for the ICD community and for those who want to insert these devices. Yeah. But let's move on to another pharma trial, OPTION-STEMI.
Pharma, not really pharma. This is about this OPTION-STEMI. So OPTION-STEMI was a multi-center randomized controlled trial from South Korea, which randomized almost 1,000 patients with STEMI and multi-vessel disease to either direct complete revascularization or an in-hospital staged complete revascularization approach with a primary endpoint of death, MI, or unplanned revasc at 1 year. So the trial, as mentioned, included STEMI patients excluding cardiogenic shock, mean age 65 years of age, 20% women, 33% were in KELIP class 2 or higher, which is something we'll come back to, and ejection fraction on average 50%. Interesting, intracoronary imaging in this trial typically is about 10 to 20%. Here it was 25%, so somewhat higher as usual. FFR, which was basically mandated for intermediate lesions in the non-culprit arm, occurred in 1 out of 2 patients. That is interesting because it's clearly not routine practice and not per routine practice guidelines. And the time to staging was about 3 days. So that is what the protocol mandated in hospital. Then, primary endpoint occurred in 13.1% of the patients in the immediate complete revasc group versus 10.8% in the stage group, with a hazard ratio of 1.42, which was, with that, the trial did not meet non-inferiority. So basically, the direct complete revascularization was penalized here. Why numerically more deaths in the immediate complete revasc group, unplanned revasc in 5% in both arms, and for some reason a numerically higher percentage of patients that went into cardiogenic shock during the procedure, 3.6% in the immediate complete versus 1.8% in the staged complete arm. Quite interesting, all these events apparently occurred during the treatment of the non-culprit vessel. So that's quite interesting. But that said, I think the trial is a little bit conflicting with the results we had from BioVasc and Multistars, all both being positive on immediate complete revasc and showing that this is actually a feasible strategy. Why is the results of this trial different? A couple of remarks. What I think is interesting that 10% in the immediate complete revascularization group of patients did not get complete revasc, 2% in BioVasc. Multivessel revascularization in only 50% of the cases. That makes also the results a little bit different as compared to the other trials in which basically everybody underwent multivessel revasc simply because they had multivessel disease, obviously due to the FFR. And then in general, the event rates were significantly higher in this trial versus other trials. For instance, CV death and MI in 9%. In the other trials we're looking at, it was about 5%. So I have some questions here. I'm not sure. To me, basically, this trial, although it had an interesting hypothesis, it doesn't really change right or practice following BioVasc and Multistars, both large randomized control international trials showing the feasibility of complete revasc immediate. So I'm I'm not convinced now that we should revisit that hypothesis.
No, I think it broadens the spectrum a little bit in how to execute strategies. There is no question that we need to achieve or target complete revascularization. So the question here was, okay, do you have to do it immediately or should you stage it within the index hospitalization? Well, I think that the important nuance there was the sub-analysis that they did in the patients with a KILIP class more than 2. So that tells me first that you need to use a stethoscope still in 2025, because otherwise there's no way that you can identify the KILIP class. But second, and this is totally in line with the culprit shock randomized controlled trial that showed that culprit only was the approach rather than an immediate complete revascularization in patients in cardiogenic shock. Well, obviously in patients in a KILIP class 3 or 4, they are congested. And so I think it's self-explanatory that they have a higher likelihood to proceed to shock, that the higher risk there. So I think if you have a patient that is decompensating on the table, well, there is no point in exposing these patients to the additional contrast load and to target a complete revascularization immediately. But at the same time, I would recompensate the patient after the culprit lesion has been treated and then take care of the remaining issues a couple of days later after recompensation. Yeah. I think this is maybe a nice takeaway from option study.
I agree, fair point, and that was also one of the things discussed in the discussion of the trial results.
But pharma.
So more trials on pharma. One was a DUAL-ACS trial, focused on the duration of DAPT following ACS. Yet another trial assessing differences in short versus long-term DAPT in patients with acute coronary syndrome. So we know there are, I think by now, 9 randomized controlled trials, a couple of them still in the pipeline, assessing different strategies, stopping aspirin, stopping P2Y12 inhibitors, different combinations, 1 month, 3 month, etc. This trial was a multi-center open label RCT designed to test the difference in 3 versus 12 months of DAPT. Initially powered to show a difference in mortality, the investigators in Scotland initially aimed to enroll 16,000 patients, but then not really sure why, but the enrollment also here was prematurely discontinued. And then a analysis of 5,000 patients was presented, presenting with type 1 MI. Initially in Scotland, later also patients were added from the UK and New Zealand. Mean age 63, 27% female, 70% had a PCI. And then basically David Newby presented the results concluding that there was no difference in all-cause death in patients with a short versus long-term DAPT, but a lower risk of major bleeding. So basically, yeah, that's the primary endpoint. A little bit in line with what we expected, so similar efficacy, somewhat lower risk of bleeding. A trial that will likely not really change the guidelines, but I think it adds to the fact that if you have a higher bleeding risk, you may want to decrease DAPT, and I think that is something that we slowly may move into in the future.
Yeah, but you know, this concept of waiting for 3 months and then decide when to proceed with single or dual antiplatelet therapy. I mean, this was studied already in the Twilight trial a couple of years ago. But who's doing that? We're thinking more about shorter durations of dual antiplatelet.
Defined up front, but I think that is also what happened here. I don't think the patients needed to come back at 3 months in order to be stratified.
No, but at least it was 3 months DAPT versus 12 months.
That's correct.
DAPT.
Yeah.
So, I mean, this is not what we're doing. We're now thinking about...
if you want to go further down, for instance, 1 month, that's good. That's a different...
Or even immediately. And this is basically what NeoMindset did. This is our good friend and Erasmus alumni Pedro Lemos, who presented and also published the NeoMindset trial in the New England Journal. This is a randomized controlled trial that was run in Brazil. And patients were randomized to either dual antiplatelet therapy for 1 year after an ACS versus single antiplatelet therapy almost from the get-go. So patients were receiving dual antiplatelet therapy during their re-intervention, their interventional procedure, but then they were then randomized to either continue the aspirin or interrupt aspirin and proceed with single antiplatelet therapy with the potent antiplatelet drugs like ticagrelor or prasugrel.
So that was open, right? So it was not mandated to use one or two?
That was open. But, this starting single antiplatelet had to be within 4 or 5 days after the index procedure. So that is important. Now, the primary endpoint at 1 year, which was a composite of death, stroke, MI, or urgent target vessel revascularization, was significantly higher in the patients who received the single antiplatelet therapy. That was to me a surprise, and that was not like one component of the primary endpoint that was driving this difference. So it was a little bit remarkable. And if you then look at bleeding, so BARC type 3 or 5, these were significantly higher with DAPT. As a matter of fact, if you look at the net adverse clinical event rate, it trended in favor of single antiplatelet therapy. So I was a little bit confused and also a little bit disappointed, because this is for the first time that there is like a real penalty with premature aspirin interruption. So then the question is, okay, did they interrupt aspirin too soon? And should you then at least have 1 month of DAPT to prevent, for instance, stent thrombosis or other acute procedure-related events? But it was not so clear that you saw more stent thrombosis in this trial either. So I was a little bit, confused, and I didn't know what to make about this. Not convinced yet, and that's why I'm also very happy that we have the Legacy ACS trial that is still ongoing, wrapping up its enrollment in this month, because this is not the end of the story of very short-term DAPT.
No, and I think it's always the question on how you define endpoints, why TVR in this endpoint, whereas bleeding, I think, should have been in the primary composite. So I'm a little bit...
It's always controversial to combine thromboembolic and bleeding events in one net adverse clinical event rate, but it has been done before, and it was also done in the Target First trial. That is the other trial that was published and presented at the same day, published also in the New England Journal by our good friend Giuseppe Tarantini. This is a randomized controlled trial, again looking at patients who underwent PCI for ACS, so either STEMI or non-STEMI. Patients were randomized to 1 month of DAPT versus 1 year of DAPT. So a little bit of a different protocol. More than 2,000 patients, 2,246 patients in Italy, Portugal, Netherlands, Spain, and France. And then also very important, they had non-complex coronary anatomies and also a low bleeding risk with proven complete revascularization within 7 days of the index procedure. So you could do complete revascularization or a staged complete or immediate or staged complete, but within 7 days of the index event. So this is important. Eventually, 1,942 patients were randomized. So you had more than 2,000 patients screened, 1,942 patients randomized, mean age 61 years old, 1 in 5 women, 50% had a STEMI. And here, DAPT was either aspirin and tica or prasu versus a single antiplatelet therapy after 1 month, dropping the aspirin and continuing with ticagrelor or again prasugrel. The primary endpoint was NACE, so not MACE, but NACE at 1 year, a composite of death, MI, stent thrombosis, stroke, and major bleeding. Major bleeding defined by BARC 3 or 5. And this primary endpoint occurred in only 2% at 1 year. Amazing. And more than 50% relative risk reduction in bleeding, specifically BARC 2 bleedings in favor of the single antiplatelet therapy after 1 month. So I think this is an important study because it underscores that probably it's safe to drop or interrupt aspirin at least after 1 month. The question is, can we drop it earlier? Well, based on neo mindset, we have to pull the brakes here for a second. So at least 1 month of DAPT still is, I think, recommended after the treatment of an ACS.
And this trial obviously relates to somewhat low risk patients, lower bleeding risk, complete revasc, not too complex disease, which is reflected in the somewhat arguable event rates at 1 year.
But definitely not the end of the story. Again, Legacy is looking at single fail antiplatelet therapy from the get-go after the procedure. And COMPARE-STEMI 1 is also in STEMI patients looking at 1 month DAPT versus 12 months of DAPT. Okay. What then?
Something completely different.
Blood pressure?
Blood pressure. No wrap-up without blood pressure.
There you
So
go.
this is an interesting trial called Outreach that looked at the adherence to treatment and blood pressure control. Why is this of interest? I think we know that non-compliance is frequent. Nobody realizes it, but it's about 50% of patients that are non-compliant to drugs. And specifically for those on antihypertensive drugs, it's an issue because if you're non-compliant, your outcome is worse. And that's something that has been widely studied. So this multi-center trial enrolled 200 patients who got at least 2 antihypertensive drugs, 12 sites in the UK, basically randomized or divided into 3 groups, A, B, and the control group. So A, B would be the patients that underwent drug testing and then had signs of non-compliance. They were randomized into confronting the patients with reports saying, hey, listen, you are non-compliant, please increase because otherwise you'll do worse. Or group B, non-compliant, and then result was hidden from the patient versus a control group, obviously, which were the adherent patients. What the investigators showed, a little bit in line with what we found in a RHYME trial here in Erasmus, is that the baseline mean adherence rate was about 50%. So confirming previous data. But there was no significant decrease in blood pressure in the intervention group versus the group which was kept unaware of the result. There was a 5% difference in office-based blood pressure, but that did not reach statistical significance. But there were some lower costs associated to that. So showing a conceptual point, naming that if you want to improve your adherence, you can test for adherence and you can confront the patient with a result that may increase adherence rate, about 10% in this trial, and may decrease blood pressure, but larger trials would be needed to show that.
So are you saying that confronting the patient with the fact that they were not compliant only increased the adherence with 10%?
10%.
That's nothing.
That's not a lot. And well, I mean, it's 10%.
It's nothing. 90%, no.
That depends on how you define nothing. Wow. I think at the end it will be about what is the delta in blood pressure and what is the clinical outcome to be expected as a result from that. It's a costly therapy. It may be a couple of €100 per patient to do the compliance testing. So, yeah, we need to. I think.
But come on, Joost, this tells me that a more mechanical therapy like renal denervation makes much more sense.
That's the second thing I wanted to say. I think the key message here is that we can try to improve it, but it will be difficult. And likely, indeed, invasive therapies like renal denervation may be more appealing options to patients who are, for some reason, not compliant. Yeah. Also, Simone Biscaglia, our good friend from Italy, presented the 3-year results of the FIRE trial. So you recall a couple of years ago, multi-center trial studying whether complete physiology-guided revascularization is superior to culprit-only PCI in patients at the age of 75 years or higher. 1,445 patients. The trial reported a 27% reduction in the primary endpoint at 1 year. And now at 3 years, the event curves basically remained parallel, telling us that the direct physiology-guided complete revasc in these patients is superior to culprit-only PCI at the short term at 1 year, but also at 3 years, in which there was still a 28% event reduction. So basically similar to the 1 year reduction. Just as a short note for a trial that we noticed at ESC. Another trial of interest, completely out of the box, but something very contemporary, was the AI-Gatekeeper trial, a multi-center, open-label, Korean randomized controlled trial that enrolled 450 patients with suspected coronary artery disease. To determine the efficacy, safety, and cost-effectiveness of the AI-Gatekeeper software to assist clinicians in diagnosing coronary artery disease with a primary endpoint of predicting lesions more than 50%, using a multimodality AI technology that integrates all forms of clinical testing, so baseline risk profile, blood tests, chest X-ray, EKG, echo, in order to predict whether patients should either go to a coronary catheterization or nothing, or whether they should go invasive testing and predict the likelihood of that. Primary endpoint, MACE at 24 weeks, with a secondary endpoint being unnecessary advanced imaging. So basically, clinical endpoint and testing whether the AI model would reduce the number of unnecessary CATs. Again, 450 patients, mean age 55, mostly atypical angina, so as we would classify low-risk patients. 76% reduction in unnecessary advanced imaging, being either CTA or invasive coronary angiography, and an 87% reduction in MACE, mostly driven by less acute coronary syndromes. So I was quite flabbergasted. Why such an enormous reduction in ACS in these low-risk patients, only 450? That said, I think it shows at least the concept of the potential of an AI model using all these different physiological tests in predicting the risk that a certain individual may have significant coronary artery disease.
Intriguing.
Yeah, I think it's really intriguing, and it shows that we really need larger data sets in order to validate these concepts and potentially start using them in clinical practice, in which we know that 50% of the angios we do is just to rule out disease. These patients have nothing, or at least no significant disease. Yeah. So it is relevant also from a cost economical perspective.
All right, then the last trial that we wanted to briefly mention is the POTCAST trial. This was not featured in our preview, but I thought I was a little bit stunned by this trial because I thought it was very well designed. It was really in sync with clinical practice, and it had immediate clinical effects without adding a lot of costs. What does this trial evaluate? So it looks at optimizing serum potassium levels with a sweet spot that seems to be between 4.2 and 4.5 millimoles per liter. So the target of this trial was to increase the potassium to 4.5 millimoles per liter. This was a randomized controlled trial including 1,200 patients, mean age of 62 years old, the majority men. Ejection fraction was 45%. 50% of the patients had an ICD. The other 50% had a CRTD. And 50% had an ischemic cardiomyopathy. The potassium at baseline was 4.0 millimole per liter. So just the question here is, if we just get these patients to a little bit higher level of potassium, do we then make a clinical difference? Well, the treatment arm to increase the potassium levels was based on potassium supplements, MRAs, and a potassium-rich diet, so very cheap. A very cheap way of increasing, elevating the potassium levels. And the primary composite was death, heart failure hospitalization, and ventricular arrhythmias. And they found a 25% relative risk reduction that was driven by fewer ventricular tachycardias. I think this was a beautiful study. I love this because this is so, it is logical, it makes total sense, but it also has immediate implications. We can do this in our practice tomorrow or even today. And we all know how to elevate this potassium level, and we need to be a little bit more sensitive that, you know, there is an optimal potassium level, and that probably is close to 4.5 millimoles per liter. And by implementing this, you will reduce the risk for ventricular arrhythmias. I liked it.
I agree. Very intriguing. I'll keep eating my bananas and tomatoes. And with that, I think we will conclude this very lengthy wrap up on a meeting that really was great and presented with a lot of interesting data.
Absolutely. ESC Madrid was very successful. So now, thank you very much for being with us for this wrap up. And we're getting ready for the preview of TCT 2025. Thank you very much.
Thank you. Bye-bye.